Awesome.
Thank you. How do I? Uh-oh.
The big green. No, the big green one center.
The big, obvious green one? Thank you. I have no disclosures. By way of introduction, I'm Morag Yule. I'm president of STAR. I'm a clinical psychologist, but also trained in sex research. So I come at this work from a scientific background, but I was really drawn to the clinical aspects of patient care because it's fascinating that therapy can change the way that the mind, the brain, and the body functions, and that's very relevant for sexual health. And so, by way of introduction for STAR, which is the Society for Sex Therapy and Research, this is an organization that's 50 years old this year, and the mission is to foster clinical practice and research. And to do that, we're really focused on the intersection between sex therapy and sex research. Evidence-based clinical care, as you all know, is vitally important, and that's especially true for sex therapy. So we support this work by providing a communication forum so people can discuss clinical cases, where people can share resources, provide referrals. We have an annual meeting. Next one is in Philadelphia in April, a clinical case conference. We also have a Find a Therapist part of our website, online workshops, and collaborations. I'm sharing all of this because I think a lot of it will be highly relevant for you, even if you're not doing psychotherapy yourself. The first thing I want to talk about is why sex therapy? Why therapy in general, and more specifically, why sex therapy? First of all, I really think that people underestimate the impact of physical health, and you'll see mental health concerns on sexual health. So research shows that for men who have diabetes, and I know you all know this, but 75% comorbidity with sexual health with sexual concerns. Same with women with breast cancer, 83% comorbidity with sexual concerns. Heart disease, psoriasis, endometriosis. I could probably make this connection for most physical problems, that there is a high prevalence of sexual concerns because mind and body is not really separate when it comes to sex. This is even more prevalent in mental health concerns. So 70% of people who have diagnosis of depression also have sexual concerns. It makes sense, right? Lack of motivation for things you're usually interested in, but also the physiological impact of the depression, and then sexual dysfunction is also depressing, so it's kind of can go back and forth. 80% of those with OCD, 70% of those with psychosis, 40% of people diagnosed with ADHD, again, this is highly impactful, and 85% of veterans with PTSD also have erectile dysfunction. So mental health and sexual function are very, very highly linked. I want to talk a bit about distress. And I know you know this, but the DSM-5 diagnostic criteria for sexual dysfunctions all include persistent and clinically significant distress, right? But if we really think about that, distress is a negative emotional state characterized by feelings of anxiety, worry, discomfort, or suffering. It occurs in response to stressful events, challenging situations, psychological strain, and it can manifest physically and mentally. And this is really important because what we're actually talking about is fight or flight, right? Distress is the subjective feeling of sympathetic activation, which includes the release of cortisol. And John Mulhall himself at the STAR meeting a couple of years ago said that cortisol is the anti-erotic drug, right? And so we've got a really strong feedback loop here. So the distress of a diagnosis is impactful, a sexual health diagnosis, or a mental health diagnosis, or a physical health diagnosis. And it's going to impact people's sexual systems. Illness is not sexy. And it really, nowhere else except for sex is mind and body so closely related. And so while I'm thinking about distress as being in the mind, I really want to talk about, sex therapy is therapy plus. Really, as a clinical psychologist, when I'm treating, I treat mostly sex therapy patients, but I'm really thinking about treating the entire person, right? I'm thinking about anxiety disorders and diagnosing for OCD. I'm asking them about their digestive health because that can be related to pelvic floor problems, and that's also related to sexual health. So I'm thinking about the whole system, right? And so I'm really thinking about sex therapy, especially for medical providers. You're also thinking about sexual health, but you're thinking about it from like genital up, right? And I'm thinking about it from brain down. And I think we all need to be thinking about both of these things together. And so psychotherapy in general can help to regulate distress. It can significantly reduce symptoms of psychiatric disorders, and it can really do a lot of really great work on things like relaxing pelvic floor muscles, for example, reducing cortisol, physiological aspects of health. And then sex therapy is an additional skill that can improve sexual symptoms and reduce sexual distress. And I do want to say, like, even when there is a very primary physiological reason for a sexual problem, cancer, hormone problems, the mind is very much immediately involved. And so once you cure a sexual problem, you may still have to deal with the kind of sexual fall or the mental fallout of that. I might be biased, but I really do think that the brain is the biggest sexual organ. I mean, maybe you could argue the skin, but the brain itself really processes sensory information. It regulates hormones. It influences desire and attraction. It manages emotional and psychological aspects of being a human. It handles stress and anxiety and supports sexual confidence. All of these things are related to mental health in general, but also to sexuality and people's experience of it, and particularly their experience of distress when things aren't going well. So, sex therapy, where have we been? You might recognize this picture of Masters and Johnson. And I need to take you back 50 years rather than 25, because Masters and Johnson developed some of the earliest models of sexual response back in 1966. And their first mentions of sex therapy were around 1958 in applications for funding to their university, which is relatively recent, really, to have that's the first time sex therapy is mentioned. But so the early models of sexual response by both Masters and Johnson and Helen Singer Kaplan, they're very linear, right? And so it kind of goes from desire, excitement, orgasm, resolution, and then a refractory period. And this is still how many of us and many of our patients think about sexuality and sexual response, and I'll get to that later. Early sex therapy really focused on sex specifically, rather than talking about like relationships or other parts of being a human. And sex education was really, really important at the time and continues to be. So psychoeducation just being the combination of information and education with elements of psychological therapy. It's shown, it's an intervention in and of itself. And so all of you here, when you're giving information about sexual function and really letting people know how sexuality actually works and what they can expect from their treatments and their medications and their surgeries, it's really important and can actually help them to have improved symptoms afterwards. And really the goal is unlearning and relearning what we know about sex. Okay? And this is very much a part of the therapy that we continue to do today. I'm going to rush through a little bit because I know we're short on time, so if you want my slides later, you let me know. Masters and Johnson also developed a sex therapy technique called sensate focus. I've heard this talked about several times during this conference, so I know you all know what it is. But really, it's one of the oldest evidence-based approaches to treat sexual difficulties. It's a stepwise approach, and it is involving a non-sexual, non-genital touch to focus on physical sensations without pressure to perform. It's based on the idea that performance anxiety, or that cortisol, or activation in the body, avoidance, relationship problems, and distraction are going to interfere with sexual arousal. So we want to take the pressure off. We want people to get used to spending time together, touching each other in a way that doesn't feel like there needs to be any pressure for any sexual outcome. And it really works, I still use this to this day. It's very much used, it's more used as a mindfulness exercise now, and it's a stepwise tailored to the individual rather than it being a standard stage exercise at this point. So today, we're really working with an updated model of sexual response. So this is developed by Rosemary Bisson in around 2000, so 24 years ago. And this model is based on the idea that sexual desire actually, or very often emerges in response to sexual stimuli or interaction rather than it being from spontaneous arousal. So spontaneous desire, physiological desire, may still be part of the picture for some people, but desire in response to sexual stimuli is actually a really important way of seeing this. It normalizes different patterns of desire. It reduces anxiety for individuals who don't experience that spontaneous desire that we're all told that we should by movies and social media. It encourages a shift in mindset for people, so recognizing that desire might develop over time and through intentional intimacy. And you can see in this graph, I won't go through it in any depth, but what it's really talking about is asking people, like, why do you want to have sex in the first place? Right? Like, what are your reasons for having sex? And there can be all different types. They can be reasons like, oh, I wanted to experience pleasure in my body. I wanted to have an orgasm. I wanted to be close to my partner. These are great reasons to have sex. But if the reason is, I don't want my partner to be mad at me, right? Like, that is not going to be a reason for that desire to show up, right? It's more kind of like a fight or flight reason rather than being conducive to pleasure, which is really what we want people to be experiencing in sexuality. We need to be considering what sexual stimuli that they are interested in and how much of that is present. We need to be considering the context in which they're having sex. Is there a pile of laundry sitting in the corner that they're thinking about folding? Does the door have a lock on it, or the kids home? Like, these kinds of things are actually really important to whether or not desire shows up. We also need to think about biopsychosocial factors, as in, medically, is everything okay? Anxiety is present. And then once all of these things are relatively well aligned, we might experience some responsive desire after sexual touching starts. This is a game changer for people, and there is some research evidence to back it up, but when I talk about this with my clients, they are so happy that their sexuality actually fits a model that they can work with. Cognitive behavioral therapy is a really common, psychotherapy technique in general, but what it does is it focuses on changing negative thought patterns and behaviors related to sexual issues in sex therapy. The debate yesterday where the perception of penis size I thought was interesting, because what we're talking about there is like, oh, thoughts, right? Thoughts are not always facts, but they do impact sexual function and they do in fact impact emotions. And so cognitive behavioral therapy asks us to re-examine like what we have learned about sex. How are we thinking about it? Can we think about sex in a different way? It also has behavioral changes, or asking people to stop avoiding things or to try new things, or changing their behaviors in a way so that they can change the way that their emotions work. Also working on reducing avoidance. This is a cognitive behavioral therapy model that I think probably most of you have seen. But one thing that I do want to point out is that, so cognitive, so thoughts, behavior, emotions, and I always use this diamond CBT model, which is different than the triangle that many people have known, because the body is an essential part of being a human being. And a lot of cognitive behavioral therapy somehow misses that part. But for me as a sex therapist, I'm really thinking about it as like, okay, like we are a whole being with thoughts, feelings, behavior, and a body. Mindfulness is a really relatively novel sex therapy technique, but it's been around for about 20 years. Laurie Brotto in Vancouver is one of the leading researchers who's working on this, and it's probably the gold standard sex therapy technique at this point. There's a lot of research evidence that it does help people to tune into sensations in their body. It helps to reduce anxiety. It helps to increase connection. It helps people know what feels pleasurable in their body. And it also helps to cultivate a sense of compassion and self-acceptance. And so you can see how being able to pay attention and be present in the moment without judging oneself is going to create more ease in the body, which is going to allow more sexual arousal and pleasure, which is what we're all wanting. And this is a graph, because I know you all love graphs. So this is a graph showing that cognitive behavioral therapy and mindfulness were better than control for treating sexual issues after prostate cancer. I also wanted to give a nod to Dan Waters' existential sex therapy. This is based on the idea that there's deeper meaning and purpose in sexual experiences than we often think. It's very easy to reduce sexuality to a body part and whether or not it works. But actually, sexuality is one of the most vulnerable parts of being human, is really deeply related to how we see ourselves, our identity, ourselves as a partner, and ourselves in the world. And so this kind of work, we're really talking about like deeper issues, like how people are feeling in terms of like how much freedom they have in the world, how much meaning they have in their sexual relationships, how authentic do they feel, how connected they are to their partners, is their life aligned with their purpose and values. These are really important things for people, and if there's something off kilter, it can really impact sexual function. So before I go into this, I just want to say, you can see from like CBT, mindfulness, existential work, like we're really treating a range of things in sex therapy. It's very much, working with the person in front of us, how they are presenting, what they are needing, and trying to understand and work with whatever level they're needing. So sex therapy into the future. So I think that one of the things with sex therapy is that we haven't lost anything that we did in the past. Like we still do the psychoeducation, we still do sensate focus, and now we see sensate focus as a mindfulness exercise and also as an exposures exercise. So we're updating how we're seeing things, we're adding things to the toolbox, we're refining our work, and we're adding more as we go. So the new therapeutic modalities are really incorporating artificial intelligence, apps, online resources. I think there's always going to be a human touch thing that's really important. Sitting in the room with someone, like having that shared emotional energy. I don't think we're ever going to be able to get away with that, and that's good. But AI chatbots, they can really give some really great psychoeducation that is geared very directly to what a patient is needing. Interactive apps, there's like Blue Heart, Rosie, they provide guided exercises, mindfulness techniques and information, and that can be used for couples. So again, low cost, easy to access. These are really important resources. And websites and online courses. OMG Yes, in particular, is a really good one for women who are looking to explore sexual pleasure. I recommend it to almost everyone. Virtual reality is another one that's coming up. There are applications in psychology more broadly, even for issues like psychosis, autism, ADHD. But people are starting to think about how to use this in sex therapy as well. Might be helpful for exploring sexual arousal and improving sexual skills, and also exposure therapy if people are experiencing an aversion or some anxiety around sexual function or sexuality. And then psychedelic-assisted sex therapy also has some potential. Again, you all know that it has a lot of buzz in terms of therapy in general, treating treatment-resistant depression, PTSD, these sorts of disorders. But also there is recent evidence that shows that people treated with psilocybin reported positive changes in sexual functioning after treatment compared with people who were taking escitalopram. And also some evidence that people who are microdosing psychedelics experience some positive effects. So I want to finish off by reinforcing this idea that there are some things that we never want to change. A lot of these things that we're talking about is just another way to be working with mind and body together, right? We're just getting better and better at that. And I think that it's, maybe there was a separation, I should have mentioned this earlier, in like around 1998 when Viagra came on the scene and people kind of went to the more physical treatments for sex. And it was, sex therapy, I think, took a hit there. But it's really, we're realizing that it's not the only thing. Like I see a lot of people who have taken Viagra, been prescribed Viagra, and then come back because it just wasn't enough, or it didn't work because they hadn't actually gotten at what was going on in their mind. Integrative care is key, right? I think it is the future of sexual medicine. I think that no matter what tools we're using, whether it's prosthetics or surgeries or hormones or medications or sensate focus, all of the things, I think we need to be working together. And I include pelvic floor physiotherapy in this as well. I really think that we need to be working as a team. So I would really recommend, if you're interested in trying to think about sex therapy and incorporating that into your practice, gather a network. STAR is a great resource for this. SMSNA, I think, is working on a find a provider part of their website for members. ASACT also has sex therapists. Pelvic floor physiotherapists can be found in the United States at pelvicrehab.com, again, an essential adjunct to most sex therapies. And then psychiatrists, psychologists, nurse practitioners, counselors, and social workers are all really important. And collaborations, we're working on it. You can email me if you have questions. Thank you.